Good afternoon, everyone. I hope everyone had a healthy lunch and had an opportunity to take a stretch and get a few steps in. It is my distinct pleasure to introduce Dr. Christopher King, Associate Professor and Chair of Health Systems and Administration for Georgetown University Medical Center. Dr. King will be providing our keynote this afternoon of sustainable mental health programming to the community. Dr. King was also the presiding speaker earlier this year for our technical assistance webinar on institutional racism in healthcare. To view that webinar, we will have the links available post-conference so that you may take benefit of all of the webinars in our technical assistance and professional development series. We are thrilled to welcome Dr. King again for our conference this year. Dr. Christopher King is a national thought leader dedicated to transforming healthcare through research and education. He is Associate Professor and Chair, Health Systems Administration at Georgetown University Medical Center. As Chair of the Department of Health Systems Administration, Dr. King provides visionary leadership and oversight of undergraduate and graduate academic programs. As Associate Professor, he teaches and contributes to scholarship on the creation of equitable systems of care within the context of national health reform goals. Prior to joining Georgetown University, Dr. King served as the first Assistant Vice President of Community Health for MedStar Health, a $6 billion not-for-profit healthcare system comprised of 10 hospitals in the Baltimore, Washington region. He has a heart for bridging the gap between medical care and public health with a focus on contributing to community-based planning, implementation, and evaluation. Dr. King is incredibly well accoladed, including Director of a federally qualified health center in Southern Maryland, former Chairman of the Consumer Health Foundation Board of Directors, Fellow at the American College of Healthcare Executives, and served as the Washington, D.C. Department of Health State Innovation Model, the Commissioner for the District of Columbia Commission on Health Equity, the Senior Fellow of the Health Research and Educational Trust. His national investigations on screening and barriers to care among cancer survivors by race and ethnicity were published in the American Journal of Preventive Medicine and the American Journal of Medical Quality. His thought leadership around Black lives and the triple aim was recently published in the Journal of the National Medical Association. Dr. King, thank you for joining us today and all of your work in fighting disparities and assuring health equities within the nation.
Thank you, Sunny. Just audio check. Can you hear me okay?
We can.
And can you see me okay?
You look great. Let's bump the volume up just a little bit on the voice. That would be great. And then I'm going to...
I'll put on my earpiece. I think that'll help.
Okay. And then I'll go ahead and transfer to you as well the presenter screen.
Testing.
Loud and clear.
Okay.
Sounds great. And I'm sharing the presentation screen with you now.
Okay. Wonderful. See my screen.
Yes.
And you can see me and you can hear me. Yes.
Absolutely. Looking great. Thank you, Dr. King.
Thank you so much, Sunny, for this introduction. And to all on the line and listening, thank you for your patience. You know, technology can really get us at times. And this was one of those moments. And I had been prepared and ready to go, and just things happen. So thank you for your patience. Sunny, thank you for having me again and for that introduction. I actually just left the Hoosier State just a couple of days ago. I was visiting my grandmother, who is 99 years old. She lives right outside of Evansville, Indiana. So it's good to be reconnected with the great folks of Indiana State, and I commend the state for taking such a serious approach to improving health by applying a cultural competency lens in how you do your work. Clearly, needless to say, our nation is in pain. And in our work, in my work, I like to refer to this moment as a season of inflection. Given the state of our nation, it's important that we allocate this protected time to learn and to engage on this topic for our health and for our healing. So as mentioned in my bio, my work focuses on the bridging this gap between healthcare and community with the fundamental understanding that health is mostly shaped by what happens outside of the walls of the healthcare institution. My goal for our time together is to take a moment to reflect on the state of our country. And I want to do that to set the stage for why now is the time for the most unorthodox approaches to community-based mental health programming. And by sharing my own experiences in the field, I hope to convey a few lessons that we have learned in practice, hoping that this exchange of information will be helpful in the important work that you do each and every day. My entire career has centered around the eradication of differences in health outcomes with special emphasis on race and socioeconomic status. And in the beginning, like so many others, when I was early and blossoming as a budding healthcare leader, I thought that if we could just increase access to care for people through insurance, and if we can provide more culturally and linguistically appropriate care within the walls of our healthcare institutions, we make significant progress. And while these are important parts of our work, as I evolved intellectually, it became increasingly clear to me that these types of interventions just skim the surface of what's actually needed to overcome health disparities. My experience as a member of the senior management team at Greater Baden Medical Services taught me this. Greater Baden Medical Services is a federally qualified health center. It's located in Southern Maryland. And for those of you who are unfamiliar with FQHCs, they are gems. They provide primary care as well as a comprehensive set of wraparound services targeting low-income persons, persons who are uninsured, persons who are underinsured. These centers also provide care to immigrants and the undocumented. No person is turned away because of inability to pay. And during my time at the center, we did great work. It was one of the most memorable points of my career. We improved our capacity to integrate behavioral health services in primary care. We also implemented the class standards. We received a $1 million grant from the Office of Minority Health to operationalize class standards and how we delivered our care. We provided free transportation and case management. We were doing all kinds of wonderful things, but we weren't seeing significant progress in the chronic disease conditions of the patients that we were serving. So my takeaway, again, I was early in my career, it became clear to me that when people are historically marginalized, when people are oppressed, when people are descendants of generational trauma, they experience, whether it's real or perceived, this limited locus of control. This results in poor mental health. It results in unhealthy decisions, destructive behaviors, and social ills that are a threat to individuals and the general public. This is when I wanted to dig a little deeper, and I delved into those hidden markers that drive health, but are not necessarily embedded in how our work is organized and how our work is delivered and how it's funded. And speaking of chronic stress, allostatic stress load, cortisol, microaggressions that people experience each and every day, the weathering of telomeres, epigenetics, and so on. And at that moment in my career, I began to critique healthcare as we know it. Sorry, I'm gonna change the slide. I began to critique healthcare as we know it. I asked, are we myopic in our thinking? Are we asking our patients the right questions to better understand the dynamics of their lived experiences and how they move about the world? Has our focus been skewed more towards medical care versus healthcare? And when I say healthcare, I speak to the physical and the social conditions that influence our health. It's clear, yes, we can provide high quality, culturally tailored care within the walls of our institutions, but the health of the populations under the auspices of our care is contingent upon the infrastructure of the broader community. Health is mostly shaped by where we live, work, eat, and play. And I argue that as a society, if we are truly, truly serious about improving the health of the American people, or the state of Indiana in your case, there is a moral imperative for us to think more broadly about the concept of health, healthcare, and medical care. Now, yes, this is a heavy lift, and it requires us to reflect on our history, but those reflections, which are key to uncovering the actions, those reflections are the keys to uncovering the actions that are necessary to undo the damage. I learned so much working for an FQHC. It was great training. It's a great place to visit and learn for those of you who are unfamiliar with the great work of community health centers. The work was great, and it was so wonderful that I was able to land a position as the first vice president, as Sunny mentioned earlier, of community health for MedStar Health, which is the largest health system in the Mid-Atlantic. And in this role, I was responsible for establishing this framework for how 10 of our hospitals would implement the triennial IRS mandated community health needs assessment. The work also included the development of community-based partnerships and implementation strategies with longitudinal outcome metrics. Now, building on these lessons, building on the many lessons that I learned from my experience at Greater Baden, I had the challenging responsibility to help corporate executives understand their privilege with an intent to reconstruct their mental models around what is community engagement? What does it look like? What are community and partnerships, and what do some of the best ones that we see in practice look like? It was my duty to help them understand the importance of empathy and cultural humility in caring for diverse populations. It was my duty to help them recognize that sustainable impact will rely on a shift in power and redirecting resources according to need, also known as equity. It was my duty to rid them from this, we, the members of the ivory tower, know what's right for the community and we can save the day. It was my duty to rid them from that mentality. And when I say it was my duty, please note, it was not written in my job description, these activities. Instead, these were my personal commitments to drive change. I'd like to introduce you to Dwayne Johnson. On the far right, in 2013, we identified hypertension and wellness in Black men, or mental health in Black men, as priorities for our community health needs assessment. Dwayne owned a barbershop in our catchment area. And at that time, he reached out to us and he shared his frustration with premature death. So many of his patrons over the years. He wanted to do something different for his community. His conviction was strong and he was a trusted community leader, well-respected activist. To make a long story short, I can take a whole day to talk about this experience. It was so profoundly amazing. But to make a long story short, we partnered with Dwayne and his barbers. He converted his barbershop into a health hub with all kinds of messaging that were part of the barbershop experience. He required each patron to have a blood pressure screening before their haircut. And during the haircut, his barbers delivered culturally tailored education around physical and mental health. All we did as the healthcare provider was provide the training. The mental health components focused on wellness, stress management, as well as topical issues such as mental health stigma, masculinity, and parenting. A reminder that this was a community-led initiative. We did not say to Mr. Johnson, hey, we want you to provide blood pressure screenings to your patrons before you give them a haircut. That was not the approach. It was a partnership, and we trusted his leadership, and we had to release some of our power because our mental models may not apply appropriately to this setting. My team was trained to be in the background and not to be perceived as the face of the work. This was not a branding moment for our healthcare system. That was another point of education that needed to occur in the work that I was doing. I should also mention that this initiative was partially funded. The funder wanted to see a reduction in blood pressure, hypertension, body mass index, and HbA1c levels. They wanted to see major change within a 2-year period. This is where we messed up, my friends, because we dreamed up some numbers based on the RFP. At the end of the 2-year period, we did not achieve those aspirational psychometrics around diabetes and hypertension. But guess what we observed that was not measured? We learned for the first time in our lives, in their lives, that many of these men, they weren't having conversations around vulnerability, around wellness, around the perils of mental health stigma, and around not engaging in community resources that can help with physical health and well-being. These men talked about what it means to be an effective parent, a loving spouse, a loving partner. And trust me, as a Black man who grew up in the barbershop, this is a big deal. This work was transformational. This is progress. Well, 7 years later, I continue to reflect on this program. The name of the program was Hair, Heart, and Health. I continue to reflect on that experience and the lessons that we learned, the lessons that the barbers learned, the lessons that my peers in the healthcare space learned, and the lessons that we can share with folks like you, those of you who are in Indiana doing great work. I think there were 4 factors that contributed to this success. One, it was a peer education model. And so we use social learning theory as our theoretical framework. The program was led by a community champion. In this case, it was Dwayne, who also introduced us to other community leaders and folks who are well respected. Those are the folks that we need to engage and see them as part of our healthcare team. And then we were in a barbershop, right? So there was routine contact because a lot of the men would go see their barber, once a week. So you have that consistency and continuity occurring. And then we had a very holistic approach. It was from, the hook was blood pressure, but once the barber got them into the seat, they talked about other things. And Dwayne was committed to ensuring that all the conversations that would occur in his shop were in the health space. Because of my disappointment with the funder, I eventually worked with local foundations and corporations in the District of Columbia and the DMV in our region to help them think differently around behavioral-based interventions and metrics for success. Perhaps we should measure the prerequisites for behavior change or the conditions that facilitate the likelihood of accessing mental health support services. If I were to do this all over again, I will apply a model like the 5 stages of change to assess readiness at the onset of the program and progress in how people evolve on the continuum over time. For all of the licensed mental and behavioral health professionals who are on this call right now or participating in this meeting, I argue that your work will be less taxing when we as a society achieve comfort in shifting power and resources to influential lay people in the community like Dwayne, those who have a willingness and the capacity to educate and present information in a way that is uniquely tailored to the receiver. I certainly enjoyed my work as at the large health system, but I'm here to tell you that as a Black man, it was very, very taxing. It was emotionally taxing because each and every day I could see how we were missing the mark. And we were just one healthcare system. There are over 5,000 hospitals in this country. We were missing the mark because leadership did not reflect the populations that were being served. We were missing the mark because our leadership could not articulate the root causes of racial differences in health outcomes. We were missing the mark because providers were inappropriately characterizing patients, they were doing this even in their faces, as non-compliant or difficult. We train our students to not use that language now. We were missing the mark because affluent board members were making strategic enterprise decisions that directly impacted populations that they could not relate to. We were missing the mark because leadership could not articulate the relationship between mental health status and systemic oppression. We were missing the mark, my friends, because we were a part of the problem. I spent 5 years in that role. It was time for me to do something different. I moved the needle just a little bit, and I wanted to give someone else an opportunity. My experience as a board certified healthcare executive allowed me to see firsthand the competency gaps in health systems leadership, particularly in light of evolving paid for performance models. This work was happening right at the, after the Affordable Care Act was enacted, and that was a game changer in how we would deliver care. And it would call for unique skill sets in healthcare leadership with a focus on caring for the whole patient and recognizing the importance of mental health and well-being. We're going to improve the health of our country. So I decided to resign from that position, take a year off. That was my goal. And I wanted to write about competency gaps in healthcare in the wake of a rapidly changing world. But before I could do that, the folks at Georgetown reached out and they were in the process of restructuring their graduate program and their undergraduate programs in healthcare management and policy to better align with the future of healthcare. Go figure. My goal was to do this as a temporary assignment. It's been 5 years, my friends, and I continue to do this work. And now I'm chair of the department. And if anyone is interested in learning more about what we're doing to prepare the next generation of healthcare leaders, I'm happy to have that conversation with you. Just a couple of stats. It's estimated that 1 out of every 5 adults has some type of mental health condition nationally. Now, if you stratify that by race and ethnicity or socioeconomic status, you'll have a totally different picture. But I just wanted to give a global figure here. All right, and close to 6% of adults have some kind of alcohol use disorder, a figure that I personally argue is underreported. Now note, these two stats are based on what we knew before COVID. Now the country is in the midst of an awakening, and this moment has serious, significant implications for mental and behavioral health services practitioners. I'm going to share a video for reflections. All right, let's see if this works here. All right, here we go. Very emotional pictures. I'm sure many of you have seen some of those photos. Clearly, our nation is in pain. And here are a few reminders. Over 122,000 people have died from COVID-19 in this country. And their survivors, many of them, are left to reckon with a loved one dying alone. Healthcare providers have had to experience death at unprecedented proportions. People have not had the opportunity to physically console one another during times of loss, during times of mourning, during times of despair. The church, which is the linchpin for many communities and a vehicle for social connection and social cohesion, has been dismantled in the wake of COVID. Black Americans are traumatized and exhausted from systemic racism and policing and other institutional sectors. White Americans are recognizing that we are not living in a post-racial era, and they are trying to find their own voice in the pursuit of racial equity and social justice. Young people are uncovering this chasm between America's values and the unjust day-to-day experiences of disenfranchised populations. And hate groups are looking for the company. They're looking for company via social media. They are in the business of grooming the most vulnerable. So this is an inflection moment for our country. And I would argue that there are three intersecting drivers when we look back on history. The COVID pandemic, and more specifically, the devastation that this virus has had on Black Americans, Hispanics, and Native American populations. The senseless killings of George Floyd, Breonna Taylor, and Ahmaud Arbery. And an unconventional presidential administration that has not been successful in uniting the American people. So we have our work cut out for us, my friends, and this moment naturally stimulates us to ask questions. How do we build capacity? How do we work smarter and more efficiently? What are the barriers that hinder our creativity? How can they be removed? How do we use our professional and social agency to advocate for communities in which all people feel loved and have a sense of belonging? And how do we foster more resilient communities should there be another pandemic? And what are the lessons that we are learning during this moment And how can those lessons inform our work moving forward? I don't have the answers to all of those questions, and I'm sure there's not a one size fits all for communities, but I do want to speak to a few observations that some of my colleagues have agreed upon, and we're working on a publication. If we as a nation can work through the following, each and every American will be one step closer to living an authentic life, optimizing their own health and wellness. This country must confront its original sin and come to terms with how vestiges continue to show up in contemporary settings. There must be a commitment to dismantle all forms of racial inequality, racial bias, and discrimination. Until then, we will all, regardless of who we are, we will all suffer the consequences. People must be respected for their differences. We must embrace diversity as one of this country's greatest assets. And we'll have to commit to social cohesion through community building and meaningful supports, because so many of our young people are struggling right now. Although we say social media has brought us together, the truth is it's tearing many people apart, especially young folks. They are going through life, they're developing and going through some of the most, they're going through a time when they're very impressionable, and they do not have authentically meaningful, loving bonds and friendships. So what does this all mean for the work that we do each and every day? I'll pose 5 questions. First, have you identified the Dwayne Johnsons in your local community? Do you perceive these individuals as key players in advancing health and wellness? See, people like Dwayne Johnson are critical actors in transforming people's lives and enlightening people who are in power. I did mention this earlier, but I was so struck by Dwayne's passion and his ability to articulate deep-rooted barriers that I had him speak to our board of directors. This was unprecedented. Just imagine a Black barber sitting in a boardroom with majority men who were older men who were very wealthy and affluent. And this barber is speaking to them about issues that people in the community face to help them better understand why we're seeing, more people of color in the ER, why we're seeing homelessness, helping them to understand why homelessness is driving up healthcare costs. It was a major turning point, and it's unfortunate that that's very rare. That is how we need to think about our work. We need to make sure that people are at the table and folks are listening, and the power is being shifted. His testimony was very powerful. It also opened their eyes to the relationship between this legacy of structural racism and its impact on health and well-being. My second question is diversity and inclusion an inherent component of how we approach our work in the community? Have we learned how to operationalize diversity and inclusion? I like to use my potluck analogy. Diversity occurs when we bring our own dishes to the potluck. Inclusion occurs when diverse people come together, and together they create a new meal that everyone enjoys. My third question, are we aware of our own implicit biases? The evidence is clear. While we come to work each and every day committed to putting our best foot forward and doing the right thing, we are not immune. We're not resistant to these biases, those unconscious behaviors and decisions that stem from us living in a world that is unjust. It shapes our thinking in ways that we would never, ever be able to articulate. And if you have not had the opportunity to take the Harvard Implicit Association test, I would encourage you to do so. It's very important that we are in touch with our biases, because our patients and community partners they pick up on that really quickly. And when it shows up, trust and confidence are likely to be eroded. My fourth question gets more to logistics. In my work with establishing community partners, I discovered some common pitfalls that inhibited sustainability in these relationships. One, many organizations don't have MOUs. And if they do have an MOU, they only have it because they needed it for a grant. I also observed that shared metrics did not exist between the two partners. Or if it was a trio or triad of partners, there weren't shared metrics. The success of the partnership was not owned by a specific individual or person or position. And the performance of the partnership was not rigorously evaluated for continuous quality improvement. So my fourth question speaks to this, does your community have a shared vision? And does each community see its contribution to that vision? And is there an appropriate level of acknowledgement, of reward, and incentives for those contributions? And fifth, are we working with partners and using our collective voice to advocate for a change in people's hearts so that we can all fully achieve life, liberty, and the pursuit of happiness? When we peel back the layers, we will have a healthier society when we just simply respect one another and embrace our differences and take care of each other. And when people's hearts change, policies, practices, and procedures just naturally fall in place. So in closing, we have our work cut out for us, and our bandwidth will be pushed to the limits. I do wish you well in this storm, and based on the stats, I'm sure each of you has been directly or indirectly impacted by these current events. That does not exclude me. I just want to quickly share with you a picture of my mother. Right before COVID, my mother was being treated. So she was undergoing chemo and radiation treatment for laryngeal cancer. And right before COVID, she successfully completed her treatment, but needed to be in a skilled nursing facility for recovery. She is currently in a skilled nursing facility, and I think we all know what's happening in skilled nursing facilities all across the country. So yes, I am also impacted by what's happening. This is what keeps me up at night, and it's very difficult. But she's doing really well. So I know that, again, all of us have a story. Each and every one of us, we have a story. And it's important for us to take care of each other as coworkers and check up on each other's health and well-being. In many cases, we would be surprised at what many of our coworkers are enduring. And if we only knew, we'd be inspired by their perseverance and their capacity to keep pushing. I wish you, your families, and all the great people in the state of Indiana the best as we go through these times together. Thank you for your time, and I hope this was helpful for you.
Dr. King, thank you for so eloquently discussing the realities of what our mental health and addictions providers face during these difficult times of COVID-19, our continued fight with racism, and the need to explore new and different ways and innovations to better support the care that we are providing to the community. We have had some very powerful comments and questions, and so I would like to ask those individuals to actually share their questions with you directly. And so I'm going to unmute them in a successive order. And I'd like to invite Alicia Sims first to present her question and commentary and share a little bit of her story with us today.
Hi, Alicia. It's nice to meet you.
Hello. Good afternoon. Thank you, Dr. Lee, for this opportunity. And thank you also Mr. King, for choosing to use your position to commit to being a trailblazer for the underdog. I value that and I appreciate that. I am the founder of a new organization that was created using an unorthodox method. We use all of our operating functions using a business process outsourcing system. So it's subcontracted or volunteers merely running the entire organization and everything that's being done. The organization is called I Am Not Bulletproof, and we create experiences that redefine the stigma around vulnerability by focusing on the strength in it. We are powered purely by passion and the history of community relationships that our subcontractors and volunteers have. Based on what you presented today, what advice do you have for an organization that uses a community voice versus a professional voice to establish meaningful collaborations? And then also, as a pioneer familiar with using unorthodox paths, what have you found to be your self-care go-tos to stay motivated and to continue to keep staff motivated?
Thank you, Alicia. So your first question speaks to what does it take to get people to catch it and really to get it and understand. And what we were very cognizant about in our work was storytelling and using narratives to speak to our humanity. And so we always have people that have different perspectives, and folks fall in different places on the political spectrum and so forth. But one thing we can't get away from is our humanity. And so I would encourage you to continue to find ways to use narratives and images, and you put all these people in a room and you tell a story, or you put a person in front of them that allows them to see that we are all human and we all really want the same things. And if we don't address populations that have been historically marginalized, we will be impacted. Everyone will be impacted in some way, shape, or form. And so that would be, that's how we did our work. And it was really important to me because, we're dealing with people who were so affluent and so wealthy that they were so disconnected from what's happening on the ground. And my personal goal, as I shared earlier, was to pull them in, because they were making decisions and there were blind spots, and it wasn't good for the community. As far as my self-care, because this work can be very heavy, it can be very emotionally taxing. I enjoy hanging around. Well, not hanging around. I enjoy the young people that I teach each and every day. I mean, these young people, they are a different breed. They see the world differently, and they give me such hope and such inspiration for a better and brighter tomorrow. And the evidence is what we see in these marches and these protests, where these folks who are very diverse are not having it. So that's important. Of course, I exercise and do all those things that we should be doing. I try and eat right. But self-care is key, and that's something that I try to be on top of. But thank you for asking, and good luck to you in your work.
Thank you so much, Alicia, for sharing about I Am Not Bulletproof and the very specific question on community engagement. It's a constant journey towards continuous collaboration. I'd like to invite Desalyn Roberts now to present your questions and comments to Dr. King.
Hi, Desalyn.
Hi, Dr. King. Thank you for your presentation. It's timely and one that speaks very much to my role as a clinical, a Black clinician in community mental health. The question I have is, how can community health providers engage with community partners like Dwayne Johnson that you mentioned to increase mental health awareness, number one, to the minority population, particularly when those populations have experienced the impact of systematic racism and have inherent negative attitudes towards access to health?
Thanks, Desalyn. That's a great question. So I think first and foremost, we always have to look at the the makeup of the team that's interacting with communities. And if the team is not diverse in its makeup, you're going to have a struggle before you. But I also learned that we can't just make this assumption that just because the team isn't diverse, that the team cannot be successful. I've seen, there was this one physician in Baltimore that I interviewed, and she was an older white woman, and the community absolutely loved her. And she was working in Cherry Hill. Cherry Hill is one of the most historically marginalized communities in this country. And the community absolutely adored this woman. And they adored her because she shifted the power. And she not only showed up when it was time to actually do work in the community, she would actually, you know, go to the community and on weekends and just be a part of festivals and things that were happening. So having that cultural humility and really being authentically present will gain and earn folks respect. The other piece, let's see, you asked about community providers. Oh, the other piece is around identifying who are your community leaders. And those folks need to be a part of your team, those informal leaders in the community, folks who will say, you know, we're going to call a meeting Saturday, and as soon as they say that, people show up. So my question to you and the folks that you work with is, have you canvassed the community to identify who those people are? And have you started the conversations? It doesn't happen overnight in most cases, especially if you're working in a community that has been exploited as a result of medical research, or there's a grant and services are provided, and when the grant goes, services go. If you're dealing with that kind of history, again, you have a struggle ahead of you. But it takes work, it takes cultivation, it takes consistency, and it takes cultural humility. And that's what we were able to do with Dwayne. And again, we wanted him to know that this is your show, Dwayne. We are here to provide, you know, we needed to do the CLIA waivers and all that wonderful stuff. All that stuff we took care of. But how he wanted to design that program was totally up to him. And the folks that I work with in the system, they had a very, very difficult time with that. That wasn't their standard way of operating with community. And I said, well, that's the problem. You know, that's why we have community members who don't think too well of us because of those types of interactions. So I hope that answered your question.
Thank you, Dr. King, and thank you, Deslin. We now invite Kanisha Smith to provide a very thought-provoking comment.
Hi, Kanisha.
Hi, Dr. King. I just made a comment when you were talking about missing the mark. I've worked in mental health and social work for a while, and I commented that I was so happy that you said what you said and that it needed to be said. I was glad that someone finally said that we've been missing the mark in providing these one-size-fits-all or these cookie-cutter services, and wanting to provide services, and I don't know how I actually want to say it, but I feel like sometimes we want to provide services from a certain manual, and that doesn't fit everyone's background. And so many times I ask myself, you know, are we missing the mark? Are we causing more harm than doing good? Because sometimes I do feel like we violate people's culture. And so I work in teams, and so many times I have to remind my teams, and quite honestly, since we're having this discussion, when you're working in child services and things like that, sometimes I have to remind other entities that I work with, you know, this family is not causing any harm. This is the culture of their family. And I try to help them understand their culture, if that makes sense, if I'm articulating what I want to say. And so many times I don't think people look at it from that standpoint. They look at it from a little lens and want everyone to fit into this, and this is how we want their family to run. instead of looking at this family as actually doing a great job. And we need to respect their culture and where they're coming from and try to provide the help that they need. Does that make sense?
Makes a lot of sense. And that's what it's going to take to build trust. Because as we know, there's still distrust. And it's because we have tried this one size fits all approach and this, this paternalistic approach to how we actually interact with communities and provide services. And we just have to stop doing that. So thank you for sharing that. And I'm with you. I'm on the front lines with you doing the same thing. And I wish you continued success.
And it's exactly these types of conversations as the purpose of the overall Mental Health and Addictions Conference, to ensure that you, our mental health and addictions providers, are receiving the resources that you need and receiving the overall community here in outreach, that you can provide the additional support and also be supported. I'd like to welcome Kelly Meyer to provide her comments as well to Dr. King's excellent presentation.
Hi, Kelly.
Hello, can you hear me?
Yes, I can hear you.
Oh, okay. Thank you. I think it's so exciting to see folks who are pillars of the community, and even if they're not pillars of the community, but they're not a political figure or someone that is seen as a leader who makes governing decisions for the community. I'm trying to get there, I'm sorry, but our Dwaynes, whether we're trying to tackle obesity, mental health, so obesity, maybe it's a restaurant, the mental health, we did it in the barber shop, something else we can do in the grocery store, but who those leaders are that maybe aren't a political figure to us, but how we incorporate that message to see when we see a champion in our neighborhood do it. This is what excited me so much about what you're saying, is then I feel like, oh, me too. If Dwayne can do it, well, I could do that, or I could be doing something too. What should I be doing over here in my flower shop? Or what should I be doing over here in my funeral parlor? Or what can I do in the bank? And so the Dwaynes would inspire me. And if there's a way that you see that little chain of events happening, if you could just, and mostly I just want to say thanks for sharing that story too, but also what those tidbits are as to how we can do the Me Too sort of thing.
Yeah. That's a good question. And so we started with Dwayne, and we asked Dwayne to identify other folks, and it was Ward 5 in DC. And so Dwayne identified other barbers, and he also identified salons. And so I didn't speak to that. So the program was bigger than Dwayne. He was just the founder. And so we engaged other barbers and salons. We wanted to make sure that we were addressing women and some of the issues that they were experiencing. And so we ended up having a coalition, if you will, of barbers and stylists who would help take the work to the next level. And that was very meaningful. We didn't go beyond that just because of a lack of resources. And we really wanted to stay narrow. And that's another big takeaway. I know sometimes we're very ambitious and grandiose in our thinking and we want to just do everything. But we also wanted to exercise discipline, because we had identified this particular issue as a priority that we would focus on for the next 3 years. And so, yes, we had all kinds of folks pulling us and saying, hey, can you do this? Can you do this? And while we wanted to do it, we still committed to being narrow and focused on that particular issue. But I think you have a really great point. And I've seen other communities, they have more broad coalitions, and these are folks who meet on a routine basis. And that's where I think I had mentioned having a shared vision. Is there a shared vision for the community? And how do these organizations feed into that shared vision? And how do your community activists and those informal leaders contribute to the shared vision? So that's a great point. Thanks for asking that question.
Thank you, Kelly, and for identifying that everyone has a hand, an obligation to be collaborative and be stakeholders within their community. We invite Lisa Boyles next to share a little bit about herself and her question to Dr. King.
Hi, Lisa.
Hello. Hello there. I actually am a suicide survivor, and I wanted to ask you directly how all of this great work that you've been doing can be applied to the issue of the high suicide rate and trying to lower the suicide rate, especially in communities that are marginalized.
Yeah. Well, it's nice to meet you, Lisa, and thanks for asking your question. I think that there's an opportunity for us to improve how we are using social media and our mobile devices when it comes to suicide prevention. I know I downplayed social media just a while ago, but I see it also as an opportunity to do some really great things. So I'm not knocking the power of social media. I just think that we're losing our way, especially folks who are vulnerable when it comes to their mental health status. So on the other hand, I think what we have to do, and I'm not an expert in this space, but I think that there's opportunities for us to better utilize social media and our mobile devices as vehicles for suicide prevention. And I know there's all kinds of wonderful models happening all over the country, but I think that that's a big piece. And then it just goes back to the core of what needs to happen as a society. We really have to get back to, this is my personal opinion, get back to a sense of community and connection. And we've lost our way. We have lost our way. And when we do that and take care of each other, I think that we will see a decline in suicide rates.
Thank you, Dr. King, and thank you, Lisa, not only for your great question, but for your self-disclosure and the continued work that you're doing in suicide prevention and reduction. Dr. King, we have so many wonderful comments for you in thanking you for addressing so eloquently the current state of our nation and also key tactics that our mental health and addictions providers can undertake as they continue to serve their communities. You showed a slide earlier that the current state of the nation is going to continue to tax the capacity of our mental health and addictions providers. What are some things that you would recommend not only for self-care, but also for organizational capacity in this difficult times?
Yeah, no, it's tough. Again, I'm one of those people. It's been really, really hard for me to navigate the space that we are in right now. So I think having your network of folks that your support network is important, whether it's family members or friends, and having and staying spiritually connected and rooted, grounded is key. And doing things to help others who are less fortunate. That can really make a big difference. It can help you, it's helped me, and it can help someone in need. So there's always someone who is in a worse condition than we are. And so I've done work finding those individuals and using whatever resources I can to give back and to help pull someone up. As far as capacity for the organization, I know that resources are stripped. I know that, I get it, I understand, and that's why I speak to pulling unconventional players into the loop. Finding the Dwayne Johnsons, working with faith-based institutions and community activists, and then having a structured way to engage those individuals and being very humble in that ask. You know, we have our credentials, many of us, and we have our experiences, but the more I learn, the more I realize I don't know. And so having that mentality and letting that be a part of who you are and how you move about the world, I think will have folks naturally gravitate to you and want to be a part of this experience, the experience of helping people achieve their best and show up as their best selves. So, so yeah, that's what I would do, and that's a creative way, and that's again what we did in many programs that we had in hospitals. We didn't just have the barbershop program, we had other community-based programs, and all of those programs centered around partnerships with the community. Those partnerships were formal and some of them were informal. But we can't do this by ourselves. We cannot do this by ourselves. So I know it's tough. I wish I had a better answer for you.
No, I think it's a great answer that we need to approach it on a day by day and sometimes hour by hour, and to know and reach out to the community of resources that we have and to find additional folks that are also walking this journey of cultural competency with us and cultural humility. I'd like to invite Carly Thomas to ask her question.
Hi, Carly.
Hi, Dr. King. It's lovely to hear your session. Thank you so much for this. My question just sort of is about an ongoing thought that I have. I currently work with LGBTQ youth in a case management role, but I've also been a part of a lot of, I guess, initiatives or projects as just a community member where we're sort of taking these creative methods and pathways to find solutions and repair harm and things like that. With those sort of roles where you're engaging community members, service providers in a capacity that's not their full-time job, say, I find that burnout or like resource limitations can be an issue in making the project sustainable. And so my question is just, do you have any concrete or tangible resources or advice to give to folks who are coming together as a community and creating a project if that project needs to come to a natural end due to resource limitations or lack of funding if it's not backed by an agency or a nonprofit or something of that nature?
So I would first encourage you, as you're conceiving an idea and you're pulling folks together, is to go through a process just to make sure that all the folks who show up are deeply committed to the work. And there are different ways that you can do that, but that's first and foremost. I mean, who's truly vested in this work? And one way to determine that is just look at past behavior and the things that they've done in the past. Sometimes you'll have folks who'll show up that are just opportunistic, or it's just they don't have anything to do when the kickoff meeting occurs or whatever. Things will happen like that. But it's important for us to go through a process to really make sure that we are identifying and we're engaging folks who are vested in this work. So that's one piece. And then the second part of your question, I believe, was around, when resources are scarce and you have to think about discontinuing a program or service that you're providing. And I didn't tell you the future. I didn't tell you what happened with Hair, Heart, and Health. That program no longer exists. And it does not exist because of exactly what you're talking about. The program was partially funded by a corporation, and after the second year, those funds were not recommitted. And so what did we do? We tried the best we could to continue to provide the services, because again, we told Dwayne that if funds run out, we're still going to be here. We made that promise. And again, that goes back to what I was saying earlier about when you're working with communities, people are smart. They will say, oh, you have some funding, you're here to make yourself look good, and then you're going to leave when the funding dries up. We have to be very careful not to do that. And so we were able to continue doing the work for the next couple of years. After the second year, I had moved on. And because I had moved on, things just didn't continue, which is unfortunate. But What I do know is we do not have the narrative, and the community cannot say that, oh, they had the dollars, and so now they're gone because the grant dollars are gone. We had to pull back on services, but we continued to do the same level of work. We just had the numbers weren't as high. We couldn't impact as many people because our resources were scarce, but we were still present and we were still engaging. So we did pull in some additional players in the community to help us. We worked with an FQHC and engaged that FQHC, and they loaned us an FTE on a part-time basis to continue the work and telling the story. But we couldn't, the program did come to an end. So yeah, so that's my word of caution. If we're doing something in the community and we have funding, or there's something that happens that makes us look really good, we need to continue to stick with it and be as creative as we possibly can to continue those services, so we don't do more harm, as we heard earlier.
Thank you so much, Carly. Great question. And Dr. King, thank you again for taking all of our wonderful attendees' direct questions. We have just a few more minutes for additional questions. For those, in the interest of time, if you would like to type it into the question plane, I'm happy to moderate that for Dr. King. Kanisha Smith added an additional comment that per your commentary, Dr. King, this is why she's such a big believer in wraparound services, using the natural supports in the community, that they will be there when the formal supports move out. Very important when working with families.
Great point, thank you.
Great. Dr. King, in the interest of data, I wonder if you would share a little bit about how you put together the DC disparity study in consideration of our state government and several federal agencies that are on the call today.
Yeah, absolutely. So this is the second edition of the DC Disparities Report. So we know, with our Department of Health does a wonderful, they put out a wonderful community health needs assessment every few years. But what we did not have in our city was a community health or a disparities report that specifically looked at African Americans in the city, because our city, like many cities, is undergoing extreme gentrification. And so what we've committed ourselves to doing is monitoring how African American, Black Americans in the city are faring over time. And so it's a mixed method approach. So we collect secondary data, and then we hold community conversations to better understand the data, right? So it's a quantitative and qualitative methodology that we use. And we try and make it very simple. We want folks to see the measurable differences between white residents and Black residents, and there's some very, very stark statistics in that report. But we don't stop at just health, because we know that health is mostly shaped by, in our community. We look at the social economic factors and tell that story as well. So it includes the health data as well as the socio and economic disparities in health. And on top of that, we, through those community conversations, we draft recommendations for how we can close those gaps. And we look at those in two buckets. One, the healthcare delivery system, what needs to be done with how healthcare is delivered. And then the other bucket is just the broader ecosystem of our city, and how do we apply racial equity lens and decision making, community development. If there's some type of real estate project happening, there needs to be an assessment to assess, well, African Americans who have lived here all their lives, they own these homes and they're priced out, they can't afford it because it's skyrocketed, the cost of living here. how can we be sure that people who have lived in the city and have paid their dues, literally, can benefit from all of the prosperity that's happening around us? I believe that gentrification can be a good thing when people are not disproportionately impacted, when people who pay their dues can benefit from all of the progress that's happening in the city. That's a wonderful thing. And that's what we're trying to get city leaders to understand and to put assurances in place to make sure that people are not disproportionately impacted by a lot of the prosperity that's happening in the city.
Dr. King, thank you for sharing your experiences, tactical items for our mental health and addictions providers to contemplate as they come back from COVID-19, and for those that are still actively serving during COVID-19. And as we look at the impacts and ramifications of continuous racism and how we can help others through a trauma-informed and better our own overall cultural competency journey. We thank you for your time, all of your efforts, and your very clear and succinct presentation.
Thank you, Sunny, and thank you to all, and I wish you the best of luck, and hopefully we can keep in touch via LinkedIn or Twitter or whatever works. Let's keep the conversation going. Thank you so much, Sunny. I wish everyone a great day.
Thank you, Dr. King.